ಸೆಪರೇಟ್ ಒಂದು ಎಷ್ಟು 4 ಇದೆಯಾ 6 ಬೆಡ್ ಇದೆ ಬನ್ನಿ
Today we'll get to know what are the types of fluids which we use in hospitalized patients. We can categorize this into 4 types of IV fluids. One commonly used IV fluid is called crystalloid. In this we have a normal saline which is 0.9% NaCl. Second is ringer lactate. It contains lactate along with that little towards the physiological electrolytes. Next is balanced electrolyte, which is almost equivalent to our body fluid, is called plasmolyte. So this usually we use in whenever the patient comes with hypovolemia or in administration of drugs. Colloids. These colloids will increase the intravascular volume and increase the oncotic pressure, thereby increase the blood pressure. This is used in shocks. The colloids are albumin. We can use hydroxyethyl starch. Third is 5% dextrose, which contains dextrose. It is also hypotonic solution. This can be used to provide energy. This can be used to provide energy, and whenever there is hypoglycemia, this is the drug of choice. Fourth is hypertonic solution. Okay, it's like 3% NaCl. It contains a lot of more salt than the physiological level. We give it whenever there is a hyponatremia with symptoms. Okay, when the patient has got symptomatic hyponatremia, we give 3% NaCl. These are the 3-4 normal categories of fluids we used in hospitalized patients. So what is the significance of each crystalloid fluids? So normal saline usually contains sodium of 154 milliequivalents, potassium, it does not contain potassium, it contains chloride of 154. So usually it is isotonic solution. It will replete the volume depletion. It will not alter the electrolytes much, but the only problem is it can cause hypochloremic acidosis. So we usually alternate this IV fluids with other fluids such as ringer lactate, which is more towards the physiological body fluid electrolytes. So the ringer lactate contains sodium of 130, potassium of 3, calcium of 3, and lactate of 28 millimoles per liter. So this usually is physiological level, commonly used in burns, surgical cases. Usually they alternate with NS with ringer lactate. It is less likely to cause acidosis unlike normal saline, but lactate, because of lactate, it cannot be given in the liver injury cases. Third is plasmolyte. This plasmolyte usually it's more like a ringer lactate, but it also contains magnesium and less chances of acidosis. So this plasmolytes can be alternate with normal saline. So this fluids mainly used to increase the intravascular volume. Fluid is used in the fluid resuscitation, in administration medicines. So these IV fluids are commonly used. Thank you. So let's take a real-time example. A 65-year-old male comes to a casualty with a shock. BP is low, 70/50. Is in altered sensorium. His pulse rate is 110 beats per minute. So what fluids, first initial fluid resuscitation we have to do it. Initially we can use a normal saline or ringer lactate alternate. So around you can push around 1 liter to 2 liters of IV fluids of NS and ringer lactate. Use both so that you are not in a risk of causing the patient of hypochloremic acidosis. You also are administering a little more balanced fluid of ringer lactate. So once there is a volume expansion, you see the BP is responding. Sometimes if the BP is not responding, especially some cases such as CLD, you might use serum albumin. If the albumin 20% 100 ml albumin infusion if patient has severe hypoalbuminemia or malnourished. So the other fluid like crystalloids such as hydroxyethyl starch is not usually used because of risk of kidney injury and other complications. You can use gelatin if it's available, which has got higher, larger molecules and increases the intravascular volume. So normally you either, so three fluids commonly used: normal saline, ringer lactate, and albumin if required when the patient comes with shock to the casualty. So if the fluid, if they're not responding to the fluids, then probably you have to think of other conditions such as septic shock, cardiogenic shock, and treat accordingly. One more example, a 65-year male comes to a casualty emergency with septic shock. There is a definite history of if LRTI, and he will come with a septic shock. So how to do a fluid resuscitation? Again, we give alternate IV fluids of NS and ringer lactate. The amount of fluids, just to for a thumb rule, it should be a 30 ml per kg, and in the fast infusion rate. See the hemodynamic stability. If there is some amount of hemodynamic stability, the simultaneously you send all the blood investigation including the blood cultures and start on broad spectrum antibiotics. So what about cardiogenic shock? So if patient has come with a cardiogenic shock and you get an early signs that patient has a cardiogenic shock, you cannot be aggressive in giving the fluids like 1 to 2 liters or 3 liters of IV fluids. In this case, you have to be little conservative with IV fluids, see the hemodynamic and take a decision on giving how much fluid has to be given. So it is the response initial few some like say around 200 ml or 500 ml once fluid you give, it is the response you see, and then take a decision. You might start on some medication like dopamine, inotropic support simultaneously, and some other mechanical way of increasing the blood pressure. So it is not a thumb rule that this amount of fluid has to be given. Similarly, in CKD patients who are on dialysis, who come with a shock, again you cannot give too much fluids like a regular normal person, around 2 to 3 liters of fluids. So this again, because the patient will not have urine output, they will accumulate the fluid and patient can have pulmonary edema. So it is not a universal rule, but it will guide you case by case. You have to take a decision case by case about the fluid resuscitation.